So, having discussed about introduction to pericardium, acute pericarditis, cardiac tamponade, now we are going to constrictive pericarditis. Constrictive pericarditis. So, constrictive pericarditis is defined as a clinical syndrome in which inelastic, thickened pericardium restricts cardiac filling. So, inelastic, thickened pericardium restricts cardiac filling. Inelastic, thickened pericardium restricts. So, basically, it's nothing but the heart is beating inside a cage. So, this is the layer of the pericardium, the fibrous layer of the pericardium gets thickened. This is the outer layer of pericardium. This will get thickened due to any underlying chronic inflammatory condition. The most common inflammatory cytokine which is involved in constrictive pericarditis is TNF alpha. So nowadays there are trials involving anakinra, TNF alpha 1 inhibitor being used in case of constrictive pericarditis. Okay. So this is this is thickened fibrous pericardium, thickened fibrous parietal pericardium. Okay, it will become inelastic due to chronic inflammatory conditions. So, chronic inflammation. So, this will act like a cage which restrict the cardiovascular filling. So, basically, ideally, the heart is supposed to beat like this. Okay. So, now what happens is the heart is beating like this. Ideally, it's supposed to beat like this. Now it's beating like this. Okay. So this will restrict the filling of the ventricles. So now we will discuss about the etiologies of constrictive pericarditis. Okay. So what are the etiologies? The most common in India is secondary to tuberculosis. Okay. So in the Western world, it's mostly secondary to cardiac procedures, open heart surgeries involving valve replacements, CABGs, coronary artery bypass grafting, etc. So then any cause of acute pericarditis can lead to constrictive pericarditis if it lasts for a longer time because of chronic inflammation and secondary fibrosis. So, is there any cause which doesn't lead to constrictive pericarditis? Yes, very small. Rheumatic pericarditis rheumatic pericarditis is basically an inflammation of the visceral pericardium. It has nothing to do with fibrous pericardium, the parietal fibrous pericardium. So it's mainly an inflammation of the visceral pericardium. So rheumatic pericarditis is very, very, very unlikely to cause constrictive pericarditis because constrictive pericarditis is predominantly an disorder of a pathology of the fibrous parietal pericardium, which will lead the fibrous elastic pericardium to become inelastic, which will eventually restrict cardiac filling. Okay, so having discussed about the definition and etiology of constrictive pericarditis, now we will go into the pathophysiology of constrictive pericarditis. Pathophysiology of constrictive pericarditis. So, what exactly happens in constrictive pericarditis? So, there is thickening of the fibrous parietal pericardium. So this will lead to the heart being unable to fill the ventricle. It will lead to the inability of the ventricle to get filled during diastole. Okay. It is like a heart beating inside a cage. It's like a heart beating inside a cage. So what all can happen because of that? Thinking about it, look into the cardiac cycle. the ventricular systole of a systole and diastole of a patient who is having constrictive pericarditis. So, initially, the patient, so this is the heart, this is the fibrous thickened pericardium, this is the heart, this is the ventricular chambers. So, consider this is the right ventricle. Okay. So now, uh, my heart is contracting. So basically, isovolumetric contraction, rapid ejection phase, slow ejection phase. Okay. So ventricle is contracting well. So after that, it's going to diastole. So protodiastole, isovolumetric relaxation, rapid filling phase, and late filling phase. Okay. So this is what is happening. So what is happening during the late diastole, the late filling phase, during the late diastole, the heart is unable to relax properly. So this is the concept that you have to get in. So during the mid and the late diastole, that's where the pathology happens to the JVP in case of constrictive pericarditis, which is mighty important in case of in entrance point of it. Okay, JVP in case of constrictive pericarditis. In case of constrictive pericarditis, it's a diastolic dysfunction, and why this happens in joint diastole. So if diastole is removed, why should there be a prominent wide descent? So that's what I used to think in terms of during my UG days. Now I have a clear answer because as I explained, it's a mid to late diastolic dysfunction. Constrictive pericarditis is a mid to late diastolic dysfunction. So it doesn't affect the early diastole. So it has nothing to do with early diastole. It is always a mid to late diastolic dysfunction. So basically, there is this is the heart, this is the inelastic fibrous pericardium, this is isovolumetric contraction of the heart, rapid ejection is slow ejection is followed by protodiastole, isovolumetric relaxation, then the early diastole, isovolumetric relaxation, then the early diastole. The early diastole phase is actually augmented by the increased pressure inside the right atrium that is caused due to increase the volume inside the right atrium due to diastolic dysfunction. So this is the reason why we are having the prominent wide descent. Prominent wide descent. So having discussed the so now we have so far we have discussed clinical definition, etiology, pathophysiology, and JVP finding in case of constrictive pericarditis. So we will also have to look something called Frederick sign. So what is Frederick sign? Frederick sign. So Frederick sign is nothing but the W-shaped JVP in case of constrictive pericarditis. So how is it different from cardiac tamponade? How is it different from cardiac tamponade? Cardiac tamponade, cardiac tamponade is a holodiastolic dysfunction. Is a holodiastolic dysfunction, whereas constrictive pericarditis is a mid to late diastolic dysfunction. Mid to late diastolic dysfunction. Okay, so cardiac tamponade is a holodiastolic dysfunction. In cardiac tamponade, what happens is the heart ventricle is not at all able to go into the proper diastole. Even the early diastole phase is affected. So that is the reason why we are not having prominent wide descent in case of cardiac tamponade. We are having absent wide descent with a prominent descent in case of cardiac tamponade. So in constrictive pericarditis, the prominent descent is still there, but there is much more. The wide descent is much more than that of X descent. So this will lead to a W-shaped JVP in case of constrictive pericarditis, which is nothing but Frederick sign. Okay. So we have discussed the JVP. So this is what is required so this is what is required in entrance point of view. Cardiac tamponade and constrictive pericarditis JVP findings. So having discussed JVP in constrictive pericarditis, now we will discuss something related to JVP, that is Kussmaul sign. Kussmaul sign. So what exactly happens in inspiration? So in inspiration, there is negative intrathoracic pressure which is transmitted to the pericardium, which will lead to a drop in JVP or a drop in right atrial pressure. So in constrictive pericarditis, what is happening is the fibrous inelastic thickened pericardium is unable to transmit the negative intrathoracic pressure which is developed during inspiration. So due to this fibrous inelastic thickened pericardium, there is no transmission of the negative intrathoracic pressure. That is leading to Kussmaul. Other causes for Kussmaul sign. The other causes for Kussmaul sign are right ventricular diastolic dysfunction, right ventricular dysfunction, right ventricular myocardial infarction, restrictive cardiomyopathy, etc. So, uh, now we will go to clinical features in case of constrictive pericarditis. So constrictive pericarditis is nothing but diastolic dysfunction of the heart. So there is impaired filling of the right ventricle. So this will lead to impaired filling in the left atrium. So basically it's a diastolic dysfunction. So it will predominantly present with features of right heart failure, such as John elevated JVP, facial puffiness, congestive hepatomegaly, ascites, pedal edema. So basically, the clinical features is predominantly of right heart failure. So since the right ventricular outflow is I mean, there is impaired filling of the right ventricle. There is the stroke volume from the right ventricle is also diminished. This will lead to reduce the input to the left atrium, which will eventually decrease the stroke. I mean, the stroke volume from the left ventricle as well. But even though the left ventricular stroke volume is reduced, the patient will not present with, I mean, the chances of the patient having symptoms like pulmonary edema or orthopnea and all are very less because there is reduced blood supply into the pulmonary blood vessels, the pulmonary leukemia. So there is it is very unlikely for a patient of constrictive pericarditis to present with breathlessness, dyspnea, orthopnea. It can present, but it's very unlikely for them to present with orthopnea, dyspnea, paroxysmal nocturnal, etc. So it is predominantly of right heart failure symptoms. So study says that most of the patients which are treated as BCLD on autopsy will be having constrictive pericarditis. On autopsy will be having constrictive pericarditis. So because even in constrictive pericarditis, there is congestive hepatitis and cardiac cirrhosis of the liver. So there are many patients who are still being treated as BCLD but are actually having constrictive pericarditis. There is something called ascitic precox. Ascitic precox and constrictive pericarditis. What is ascitic precox? Ascitic precox is nothing but usually in BCLD and all there is pedal edema which is preceded by pedal edema which is followed by uh, abdominal distension, ascites. Pedal edema is followed by ascites. But in case of constrictive pericarditis, ascites comes first, followed by pedal edema. Ascites followed by pedal edema. So why is it so? The exact cause is unknown, but still there are. It is postulated that there is a branch of hepatic vein which pierces the pericardium to drain into the vena cava. There is a branch of hepatic vein which pierces the pericardium to drain into the vena cava. So when there is thickening of the pericardium, there is impaired drainage of the hepatic vein into the vena cava. This will lead to hepatic venous congestion, which will further lead to ascites and other manifestations. So this is one theory. So it is not exactly known why ascites precox, but this is one of the theories which is which is well widely accepted. So this is the reason for ascitic precox. So basically, the take home point is before treating a patient as DCLD, always seek for JVP. JVP is mighty important because in DCLD, because of intravascular volume depletion, the patient will be having normal or low JVP. The JVP will be either normal or reduced. If a DCLD patient is having elevated JVP, always rule out constrictive pericarditis. So this is the single take home point from this video if you want So this is a single most important clinical point that you have to take out from this study. If at all you are seeing a BCLD patient with elevated JVP, always rule out constrictive pericarditis. So coming to the investigations. So first we will do, so the basic investigations in chest X-ray. So what do we find in chest X-ray? The finding that you are seeing in chest X-ray. There is thickened calcified pericardium. There is thickened calcified pericardium in case of constrictive pericarditis. And there is the hard borders are also kind of bit sharp, but always look for calcification in chest X-ray. Okay. So the very next investigation is echocardiography. So constrictive pericarditis is very easy to be mixed up in echo. So in echocardiography, the echo findings in case of constrictive pericarditis. Unless you are particularly looking for constrictive pericarditis, you won't be able, you will definitely, the chances of being missing constrictive pericarditis in an echo is very, very high. So in echocardiography, what all are we looking for? We will be looking for thickened pericardium, something called septal bouncing, increased right atrial pressure, and dissociation of intrathoracic and intracardiac pressure. Now, so coming to the dissociation of intrathoracic and intracardiac pressure is nothing. We have already discussed about that. There is thickened pericardium which is not transmitting the negative intrathoracic pressure into the intracardiac chambers. So increased right atrial pressure is nothing but the reason for the increased elevation in JVP. Constrictive pericarditis, there is diastolic dysfunction which will lead to increased pressure in the right ventricle, which will lead to increased pressure in the right atrium. And there is what is called septal bouncing. Septal bouncing, the most important thing that you have to look in echo is annulus paradoxus. So annulus paradoxus. Here you are putting a dot here and one dot here. So due to the thick and fibrous inelastic pericardium, this region won't be able to perform proper diastole. So in order to compensate for that, the interventricular septum, this region will be kind of moving like this. So this is one of the reason why it is having septal bouncing as well. So if you're putting this point as the E and this is the E dash. So E by E dash is the distance moved by the point E, and E dash is the distance point by the point on the interventricular septum. So the E by E dash will be much lower in case of constrictive pericarditis. So why is this a paradox? So basically E by E dash is an indication, is directly proportional to left atrial filling pressure. Okay, so basically E is the distance covered by the point dot we have kept in the lateral wall, and E dash is the distance moved by the point dot we have kept in the interventricular septum. So E by E dash is E by E dash is directly proportional to left atrial filling pressure. So in constrictive pericarditis, the E dash, the moment of the E dash is the point which you are kept in the interventricular septum, is much more higher, greater than that of the E. So in constrictive pericarditis, we will be having a very low E by E dash. But in constrictive pericarditis, due to impaired diastolic dysfunction, due to impaired diastole, the impaired mid and late diastole, we will be having increased pressure inside the left atrium. So despite having a low E by E dash, there is increased left atrial filling pressure. So this is the reason why it is called an annulus paradox. So that is the most important thing that we have to see in echo. Now you will go to CT. So the best investigation to see a calcification is nothing but CT. So CT just will show calcification in pericardium. This is suggestive of constrictive pericarditis. Okay. So now coming to management. So the management of constrictive pericarditis is pretty much surgical. The surgical stripping of the thickened pericardium. The surgical stripping of the thickened pericardium. So this is the reason why you have to differentiate constrictive pericarditis from DCLD. So in DCLD, as the patient is going to hepatic encephalopathy, if you're managing it as a DCLD, unless you are having liver transplant, even with liver transplant, the prognosis is very poor. So, but in case of constrictive pericarditis, we are having a definitive management of pericardial stripping. So, we should definitely rule out constrictive pericarditis in a patient who is having DCLD, especially with elevated JVP. So, this is a single take home point from this video. So, how will you manage this patient therapeutically? What are the drugs we can use? You can, so the drugs you are using as, so basically in constrictive pericarditis, the patient will be having compensated tachycardia. So even if there is tachycardia, you shouldn't use beta blocker because it is compensated tachycardia. The heart is trying to compensate for the reduced stroke volume in case of constrictive pericarditis. So beta blocker should be avoided. You have to manage it symptomatically by giving diuretics and salt restricted diet. Treat it as right heart failure. Okay. Diuretics and salt restricted diet. So, what is constrictive pericarditis in a nutshell? Constrictive pericarditis in a nutshell. Constrictive pericarditis is nothing but thickened inelastic fibrous pericardium that is leading to mid and late diastolic dysfunction. So, the clinical features, the patient will be usually presenting with right heart failure symptoms of elevated JVP, Kussmaul sign, ascites, and renal edema. So these are the four. Clinically, this is how a patient of constrictive pericarditis present to you with. So always in a patient with DCLD who is having elevated JVP, you should definitely rule out constrictive pericarditis. So JVP in case of constrictive pericarditis, there is both X descent and Y descent, but there is predominant Y descent than that of X descent, which will lead to W-shaped JVP that is called Frederick sign. So coming to the investigations, we will be having echocardiography, chest X-ray. Chest X-ray will be showing pericardial calcification. In echo, you have to look for increased right atrial pressure and annulus paradoxus. Okay. So in terms of treatment, it is purely surgical. Surgical stripping of the thickened inelastic pericardium is the definitive treatment for constrictive pericarditis. Thank you.